Well, welcome. Hello, my name's Grace Buchanan, and you've come along to the Cancer Council West Australia's update series for 2017. Today I had the pleasure of introducing you to Dr P Allcroft, and he's going to be talking about dying is a normal part of living. Some of those issues that he's going to cover are care at the end of life and a variety of other topics, including history of dying, what does a good death look like, how can you prepare for this, the spiritual dimensions of dying, a focus on living well, the demanding role of caregivers in the end of life, and if that wasn't enough, we'll even get to talk about David Bowie's last album. So Dr Allcroft is the Director of Mycoft Sleep Diagnostics in South Australia. He's a Senior Staff Specialist at Daw Park Repatriation Hospital in the Palliative Care Service there, and a lecturer in the School of Medicine at Flinders University. He graduated from Flinders University in 1989 and completed his specialist training in 1997. His research interests include symptom management and complex life-limiting illness, and he's a co-investigator in a number of the Palliative Care Collaborative Studies Consortium. That's really a name to get out there, I'll tell you, and which is one of the largest palliative care research groups internationally. We're very, very lucky to have Peter with us, but before we start the presentation, can I just do a few housekeeping things? I'd like to ask you all to just check your mobiles and pop it, if you can turn it off, great, but if not, at least to silent. And you were all handed an evaluation form when you came in, and we'd really value your feedback that if when you complete at the end, you place on the table on the outside. And there's no prize for doing it, I'm sorry, except in the hope that we can be meeting what you'd like in our next lot of discussions. This presentation today will run for 45 minutes and it'll be followed by 15 minutes of questions from you. So please do consider what it is you would like to be asking, because it's not often we have a specialist who's happy to stand here and take your questions. We are also recording today's session and the question session as well. If you wouldn't mind, we're going to place that on the website for those who couldn't make it to be with us today. So the other part of what today is it's Palliative Care Week, and I needed to make sure that it's not a thing that we usually say, Happy Palliative Care Week, but it is an opportunity and one of the reasons that Peter's with us. And the catchphrase for this Palliative Care Week is you matter, your care matters, and palliative care can make a difference. And without any further ado, I'd really like to invite Peter to the lectern.
Thank you very much, Grace. What I am going to talk about, Grace has alluded to with some of those topics. I think it's imperative that the way we look after our frail and our vulnerable in society really is a reflection of our humanity. And our patients who are facing a life-limiting illness, even those that, if it's a cancer, if it's a chronic illness, they are at their most vulnerable. And the way that we look after them and care for them is a reflection again on our society and on our healthcare system, which is in all states under significant stress and financial resources. Talking about dying is difficult, it is confronting, and many of you will have had experience with that, and it can be quite raw and it can be quite emotional. And I try to do it with sensitivity. But it may raise some emotions today, and I do apologise for that in advance. If we don't talk about it, though, how do we know it's going to work? Sports teams prepare all the time. Runners prepare all the time. If you don't prepare, you're preparing to fail, really. And so if we don't discuss it, we are setting ourselves up potentially. We're setting our relatives up as well for often a complicated bereavement. So it's those issues that I want to discuss with you today. We live in a post-religious world. Increasingly, churches are becoming smaller. I look at my elderly parents in their 80s, and my dad is still very active in his local church. But when I look at the average demographics, they're all in their 80s and their congregation is shrinking. But that used to be the community. where is our community today? Sometimes it's around schools, sometimes around sporting clubs, but we're becoming so insular and we don't know our neighbours anymore. So before I start, I do want to pay my respects to a few people. Professor Ian Maddox, with the then Prime Minister, Miss Gillard, was one of my mentors many years ago when I was a medical student. He was the Senior Australian of the Year and set up the Palliative Care Service that I work in. He was a wonderful man and continues to be very active in his mid-80s, and an intellectual mind and a caring, compassionate person that taught me a lot. Professor Doug Bridge, on the top right-hand side, is a Western Australian senior palliative care clinician, and his work and his involvement with education and care in palliative care and spirituality again has taught me a lot, and he has given me slides which I use for my own teaching of undergraduates. And Clive Deverell, who unfortunately died earlier this year, is a founder of Palliative Care, Western Australian Cancer Council, Western Australian Palliative Care, and really did so much to get the movement rolling. I'd also like to thank Paul Catras for asking me to come and speak and meet with people over the next 2 days as a member of the Western Australian Clinical Oncology Group. And Perth is one of my favourite cities to visit, and this morning's run through Kings Park in the rain was just something. It was so peaceful, it was tranquil, and it is so good for the soul up there, and you are so lucky to have that facility. So a challenge for you. If you were told you had a life-limiting illness, that you had less than 6 months to live, are you prepared for it? Would you know what you want? Would you know what's important? Who's important? Where would you like to be looked after? So I want you to think about those questions, because that's all part of planning. Advanced care planning, advanced care health directives. Many of the patients that I look after, by the time they've been suffering with a chronic illness such as COPD, severe emphysema, bronchitis or heart failure or motor neurone disease, they actually don't fear death, but they do fear and wonder how they might die. And a lot of the work that I do is discussing with patients and talking with them to answer those questions of how you might die. And one of the euphemisms I use for dying is a bit like a battery running out of strength, that as you get weaker and more tired, you might spend more time sleeping, less time interested in what's happening. You might wake briefly and see that a favourite family member's there and then back to sleep. And just like a toy and a battery runs out of power, so do you. Hoping to make it a normal part of what does happen to us as we get older, or as an illness such as a malignancy takes its hold on us. But if we haven't had the opportunity to discuss it, to plan, then we may provide treatments that you don't really want or are not appropriate. You may end up in an intensive care unit on a ventilator if you have never discussed about what was important with me in my breathing and motor neurone disease. So that's why it's important to plan. These are the death statistics from registered deaths over the last few years. 2015 is the most up to date. 170,000 deaths roughly in Australia in 2015. A third of them were due to cancer as a group. But the number one cause of death is heart disease. And you can see that you are old when you die. And on average these days, a male will live till about 80 and a woman will live till about 84 years of age. What is really scary is rocketing up the charts, unfortunately, is dementia. And it used to be way down the bottom, but it's now doubled in the last few years and is second on the list of causes of death registered on death certificates. Over time, death has become much more sanitised and medicalised and taken out of the home environment, we used to be conceived and born and die all in that same little house, all in that 1 or 2 rooms. But these days we're conceived in a different spot. Our delivery takes place in a sanitised environment, and then dying is taken out. So families aren't together anymore as big extended families. So it's really become medicalised, it's been sanitised, and people don't know about it really. And when you think about it, we are obsessed with death. Media bombards us about death. And unfortunately, we've been hit with another media onslaught this morning from Manchester, but when it's our own death, we don't talk about it. We're silent on that fact. Most people are dying in hospital, even though their preference would be to die at home, and I'll talk about how difficult it may be to die at home later. This is a famous French philosopher from the mid-1500s, and that quote's there really to show you that way back in the 1500s you died very young, but these days we're dying very old. So these are a few websites that are available for you in Australia. It's always difficult with websites. You've got to make sure they're reputable, they give you good information. These, I think, are good, particularly Dying to Talk, which is the Australian website as part of the Palliative Care Australia, and the British one, Dying Matters, Let's Talk About It. So if you Google it, it's actually quite scary when you Google the amount of information that's there. But these are some of the websites that may be there to help initiate that discussion. This is from Palliative Care Australia. Most of us do want to talk to their family about what their wishes are, but very few of us have actually ever done it. Another good website, and I like this because living well, because dying well matters. So this I've taken from the Financial Review several years ago. It was in the book review section for Atul Gawande's book, Being Mortal. And what it highlights is the way we're dying has changed dramatically over time. And I'll just find my pointer. There we are. So we used to die very suddenly, but nowadays we die little bit by little bit by little bit. And even if we're getting older, this frailty, and I'll come back to that in a little while. This is what doctors are being asked to think about now. The surprise question. And I've taken this from the British Medical Journal 2010, where they had a series of articles challenging doctors to start thinking about it. Would I be surprised if this patient was to die within the next 12 months? And what it's trying to do is get doctors to start thinking, I need to talk about this with patients. Particularly in chronic illness such as emphysema or heart disease and heart failure, trying to put a prognosis on something is really difficult. But thinking, might this person die in the next 12 months, should raise that discussion so as a clinician I can start to help you plan for your care. Some of the other cartoons in there, we dance around this quite a bit. Does he really want to know? Do I really want to know? Should I bring this up? I don't know whether I want to bring this up. And it's this dancing around these difficult topics. If I think about the poor doctor and the poor general practitioner, they're really time poor. And if I bring this up, I'm going to open up a can of worms, and I've got a whole waiting room that's just getting uglier out there. I'm running further behind. And so time-poor practitioners often don't ask the question because they don't want to have to go the next step. And often they're not well equipped to discuss it either. It's fascinating that as a junior medical staff, we are taught and we do mandatory training on resuscitation, but very few of us will actually ever do advanced life care support. That is, intubating people, shocking people, CPR. Very few of us will actually ever do it, but it's mandatory training. But we should be doing this stuff regularly, almost on a daily basis, and there's no mandatory training. It's given lip service to junior medical staff. And the junior medical staff are the ones at the forefront of initiating these discussions. So I think we need to do better. We're not perfect in that. So there's lots of reasons why a clinician may not bring it up. So this is the surprise question. Sick people, patients who are coming in and out of hospital, deteriorating little bit by little bit and becoming increasingly frail. So if we come back to the trajectories, you can imagine that if you're on this pathway here with your emphysema in hospital, get a little bit better, then deteriorate a little bit better, but you never get back to baseline where you were, we should be asking you, and you should be thinking, this is not getting right. And it's difficult because often patients recover and bounce back. It's amazing how we bounce back. The resilience in our system is quite incredible. But little bit by little bit, people get weaker and more frail. So the way we die is changing. In the mid-1500s, in the 1600s, right through even into early 1900s, we died very early, we died of infection, we died of trauma. But these days we die of old age. And because we're getting older, things go wrong and they wear out. So cancer, as you saw, is 30% of deaths. Heart disease and increasingly frailty and dementia is a huge issue. I want to just highlight that not everyone's ready, not everyone's on the same page, and so as a clinician, I need to be very sensitive and find out what's important to you. How much information do you want? Are you ready for this? And often some of the questions I ask patients is there anything that I haven't thought about? Is there anything that you're worried about? Is there something that I haven't discussed that's been bugging you? Trying to give that opportunity to bring up these discussions. And I acknowledge that often in my clinics, in outpatients, in palliative care, or on a home visit, I've got that time. That's part of what palliative care tries to do, is to provide time. It's not in a 15-minute time slot in the GP's rooms, or I look at the oncologist's booking list in outpatients and they've got 15 people to see in a morning, and you think 15 people into 3.5 hours, that doesn't go very well. It's not necessarily good medicine. So I acknowledge that I am privileged to be able to have that time to be in someone's home and to ask those questions and to sit with them while they ponder those thoughts, because it takes time. And it's not just the one conversation of getting this tick box done, it's several conversations, and it's getting confidence and trust of patients and their family that I can talk to this guy, that he will listen to me. And that's part of the art that I do. It's not the science and it's not using a drug, it's just the time taken. So I do need to be very sensitive in bringing it up and try to pace it to what you want to know at that point in time. What is difficult in the home setting is often when you've got the patient wants to know this, the family don't want to know that. Don't tell him this, because if you tell him, he'll be self-fulfilling prophecy and he'll die. Trying to negotiate that can be very difficult. Don't tell him about cancer. Don't mention the cancer word. These are all things that we're faced with at the home setting or at the bedside. So what is palliative care? And these are just dot points from the World Health Organization definition. But the aim is to try to improve the quality of care for both the patient and the family. And it's trying to minimise suffering. They say prevent suffering, but I think it's minimising, because I can't always get rid of everything. But I can try to smooth it out as much as I can. And when we get to a roadblock or a speed hump, how do we negotiate and navigate that? So I try to smooth out the speed humps, but I know that I'm sometimes not going to get it perfect. So we look at symptom management, look at both physical, the psychological and the spiritual. People get worried that when they get referred to palliative care, it means, it's the last days. its covert message, I didn't realise I was dying. And whilst the American system is a different system, and when you refer to a hospice, it's a program, it's not a building like I work in at Repat, it's a program, and you have to sign off rights in America to healthcare if you go into a hospice type program. But there's evidence that shows by early referral to a palliative care service, your length of life actually can increase. Your quality of life can increase. And those that are left behind who have been involved with palliative care often are able to have a less complicated bereavement process. Doesn't mean we get it right every time, doesn't mean we're perfect. And it is messy, just like childbirth. Sometimes it is very messy, and you might have a plan, but it can all go pear-shaped very quickly. So this is a picture of Dame Cicely Saunders, who set up St Christopher's Hospice in England in 1967, and she was quite a maverick, quite a tyrant, I believe, because one of our nurses at Repat worked with her many years ago and helped to look after her in her last days. But she was a social worker. She then became a registered nurse. Then she went on and did medicine and set up the Palliative Care Service. And she talked about total pain, that physical experience, that psychological experience, the spiritual, that it's not just addressing pain with a medicine, but it's addressing pain from a psychological aspect as well. And part of what is palliative care is all of that talking, that embracing. And the word palliative, it's a scary word, but when you look at the Latin derivatives from it, and I'm not a Latin scholar, it means to cloak, to make safe, to protect. And so whilst it's a bad name that raises people's anxieties and fear, when you think about its Latin derivatives, it makes sense. But there are lots of myths, and palliative care hastens death. Myth. I think I've said to you already, we can actually increase the length of life of people. Palliative care is euthanasia and physician-assisted suicide in a different way. Well, it's not. It's providing good care to most people. It's not just for people with cancer. We look after people with chronic illnesses such as heart disease, motor neurone disease, renal failure. Pain is not a necessary part of dying. Many patients die without any analgesia on board because there's no pain as such. Morphine and other drugs such as fentanyl or OxyContin do not hasten dying when they're used appropriately. Morphine does not lead to addiction, but these are all the myths that people bring out. And I think this is really important. I've let my partner or family down because he or she did not die at home. Not everyone can manage to die at home because sometimes the care supports are not there, the systems are not in place, or the needs are so complex that they need to be in somewhere like the hospice where the patient can be looked after and the family can be looked after and made safe. So what might constitute a good death? This is work which is published in 2000 by Karen Steinhauser, and really it's looking at the aspects that might constitute a good death. And number one, when people are asked, is good management of their symptoms, be that pain, be that nausea, be that breathlessness. People want to have clear decision-making pathways. They want to try to keep their cognition as sharp as possible for as long as possible and to have plans put in place. And that's why it's important that we do plan ahead of time. Preparing for death might be things such as a will or a funeral. I've had patients who have a wake before they actually die. Putting in place who's going to look after my cat or my dog. What about the finances? All of those is the preparation. Where might I like to be looked after? And completion really talks about reconciliation for some. For some it may be reconciling with a family member that's had a difficult time. For some it may be reconciling with their God. our patients still do want to contribute. And in my research work, patients are always very keen to be involved in either clinical research, which we are running at Repat where I work, or are involved actively in helping teach students about palliative care. So it's making a contribution, because we all do want to contribute to society, and it's one way, even when people are dying from an illness, they can contribute. And they really do want to be affirmed as a whole person. So those are some of the principles of a good death. The Grattan Institute in Australia, this is their list of what people want, and it's very similar when you look at some of the things. The control is not just about autonomy, but it's having compassionate, respectful discussions with people, being involved and being included as part of that care decision-making. And dignity and privacy. And we all want dignity for our patients. We all do want to die with dignity. These are two books that, for general reading, are really informative. Atul Gawande is a surgeon in America who's been writing quite prolifically over years, but it wasn't until his father, as an older man, had a malignancy, and he suddenly realised the health system and the way people are looked after is not ideal. He'd always looked at it from his surgical bent. And so he wrote, and this is a fantastic book, exploring the difficulties with the health system, the aged care system in America, but it resonates with what happens here in Australia. And Dear Life is one of the books written by Dr. Karen Hitchcock. She's an Australian physician who has written quite a lot on caring for older people, on dying, and has written in the Quarterly Essay. And again, this book focuses a lot on her grandmother, who had pulmonary fibrosis, scarring and stiffening of the lungs, and the breathlessness that she experienced throughout the end stages of her life, and how people are cared for. And they're really good reads to get a feel for how things happen. So let's talk about dying a bit more. Dying at home is a strong preference for many people, but as we get older it becomes increasingly harder, because the partner's frail, the patient's frail. So younger patients often have a higher preference to die at home. People don't want to die at home alone or in pain. Carers do worry, how are they going to cope physically, emotionally and even financially? And we've seen that very few do speak to their family or friends. I think having a clinician or a general practitioner who's prepared to talk is a valuable asset, or a community nurse who's prepared to talk is a valuable asset. Someone who will say there's something extra we can do. One of the things I hate to hear from clinicians is there's nothing else I can do for you. There's always something that we can try. It may not be perfect, but there's always something we can try. And ultimately, on very few occasions with symptom management, do I need to sedate people? And I'm happy to talk about that in questions if you wish. Very rarely do I need to absolutely sedate someone, because there's always something we can do. So a clinician who's prepared to sit and talk and listen is a valuable asset. This is the negative, though. I do fear that whilst I may raise expectations about palliative care, the bureaucracy that we deal with, my aged care, is a nightmare. I know our nursing staff are spending ages trying to sort out applications for my aged care. Reduced funding, and I'm talking about South Australia, so because I think Silver Chain may do it a bit better, and if someone's from Silver Chain, I'd really love to talk to them. But in South Australia, this is what our nurses are facing, that reduced funding. When we're trying to get someone out of hospital to home, the home referral unit will take them if they're dying, but they won't touch them if they're not, and then they'll provide 3 days of care. So it's getting tougher. So whilst I'm saying, yes, let's plan, let's die at home, let's do this, The reality is that, unfortunately, the government funding is getting tighter. And I touched on this before with dislocated families. I have 3 daughters, so I should be fine to be looked after in my old age. But one's already moved to Melbourne. Fortunately, one of my daughters is an occupational therapist, so I hope she may have a finger on the pulse as I get older. And my youngest daughter will go anywhere for work, and so in the next few years she may have fled the coop as well. So I and my wife may be left with no one in Adelaide to help look after us when we're older. And as I said, we don't know our neighbours these days because we're busy, kids aren't playing with each other, we're socially isolated often. So a few more websites about planning. If we don't plan, if we procrastinate, then we may leave it and make it harder for our loved ones. And we do all like control, so why do we hand it off to someone else? I've lifted this from the Palliative Care South Australia newsletter, but when we let fear or anxiety stop us, we're just shifting the responsibility to others. We decide that they'll make the decision for us, and often that is okay because they'll make the right decision, but it can be very stressful to make that decision. And several years ago I was asked to be the power of guardianship for a friend of mine who was going in for a brain surgery. It was a huge meningioma, so a non-malignant tumour, but huge, the size of a grapefruit. 8 hours of surgery. And Jenny had asked me to be her decision maker if it all went bad. And you know what? That was really scary, even though we talked about it. If it had all gone bad in that surgery, and she's only mid-40s, I was the one that was going to be charged with making that decision that enough's enough. So as a medical person and as a friend, it was scary. So what's the average person, the average non-medical person with those decisions? So making decisions, making it concrete, or as concrete as possible, does help those that have got to make a decision. Fortunately, it was all worked out fine. The only thing when she woke up in recovery was she said, "Where did you park your cow?" She had a little bit of speech dyspraxia for a few days after the surgery, but she's fine now. I like this, Jane Markley. Advanced care directives are easy not to do. We can just put them off. We plan everything in our life, our holidays, our marriage, our birthdays, so why don't we plan for our death? Why don't we sit down and make plans when we know it's coming? And most of us will know it's coming because it's not a sudden death for most of us. We will have warning. And in some ways that's a good thing that we can plan. I'm going to switch a little bit briefly and talk about spirituality, and this is a woman celebrating and reflecting on Day of Death and Saints' Day in Mexico, which is now a national holiday. And it's a day where they remember and they pray for their family and friends who have died. And it is so significant that it's actually on the UNESCO Cultural Heritage List for humanity. It has become such an important day of remembering and recalling. So Doug Bridge, the Western Australian palliative care physician, talks beautifully about spirituality, and if you ever get to listen to Doug, he just speaks so well, and it is worth spending time with him. But I'm just going to touch briefly on what is spirituality. It's not necessarily religion. It's what gives us meaning. It's validating you as a person. Many times it's asking for forgiveness for mistakes that I've made over time. For some it's reconciling. For some it's just having that peacefulness and that peaceful time. And others it's having permission to leave this world, that it's all got a bit too hard. And if you think about the list that Steinhauser has developed and the Grattan Institute of what constitutes a good death, a lot of it is spirituality. It's what gives you meaning. And one patient that sticks in my memory who I looked after with our nursing staff for several years was Trevor, who had motor neurone disease. And over the years it progressed. He was on a ventilator for 24 hours a day, non-invasive ventilator, not a tracheostomy. He had a tube for feeding. And I asked him, what keeps you going? What's important to you? And for him, he was at home, he was looked after by a carer, and the mark of this man was that Trevor had looked after Art when he was down and out, and Art said, I'm going to look after him now. And his ex-wife used to come and help look after him as well, but he's in a wheelchair. If he could see the sun in the morning, if he could listen to the morning bird's song, if he could see his garden and watch Australian movies and listen to music, that was what drove him. That was his spirit. But it did get to a point where it all got too much for him, and he did ask to have his ventilator turned off. But conversations at that time were so difficult because he couldn't speak. He'd lost the power in his hands to move his fingers, so he couldn't send us a text or write on his iPad. So we used an alphabet board, and you had to hold his sleeve and he would move over the alphabet board, and where you just felt this subtle drop in the finger, you could spell out words. So it took a long time to have discussions about when is enough, when would he like to come off his ventilator. He brought it up. Didn't want to keep pushing the point of when's enough's enough, but he brought it up, and then we said, yep, I can do that, and we'll come back and we'll do that after the weekend. And he texted or typed out for us with the alphabet board, oh good, I can watch Brand New Day on Sunday night, because that was when the ABC were running a series of Australian movies. And so watched Brand New Day on Sunday night, and then Karen and I went on Monday with district nurses to use medication to make him nice and sleepy. And when he was nice and sleepy, took him off his breathing machine, and he died peacefully over the next 20 minutes or so. So that was his spirituality. That's what drove him. And this is some of the questions that I've already alluded to. What's important? What gives you meaning? And for me this morning, it was running through Kings Park in the mist and the rain, the peacefulness, the gums. That for me was my spirituality this morning. Because I acknowledge religion doesn't play a big part in my life. But from a spirituality point of view, it's immense. And this is just another picture of Mexico and the public holiday and tending to the graves. This is another good book. I couldn't actually get the picture of it to fit in, so I've just left the title up there, The Top 5 Regrets of the Dying. Bronnie Ware's an Australian palliative care nurse, and in her discussions with people, these are the top 5 regrets, and I'm guilty of some of them as well. And over the last few weeks, I've spent a lot of time reading, thinking, writing. I haven't spent a lot of time with my family. And this weekend I'll try to make up for it a little bit. My wife's really good at making sure we stay in touch with friends. On a Friday night when we're absolutely exhausted, she says, let's catch up. Or we catch up with our good friends Kathy and Paul pretty well every Saturday for coffee at 8 o'clock. Before I head off to work for a ward round, Paul heads off to work. He's a teacher, so has school sport, etc. But we pretty well have tried to make that our rock, because they were our best man and bridesmaid when we got married, I think 26 years ago, I keep forgetting, but about that. But making sure we stay in touch with friends. So this is all things that we need to do to be living well and preparing. A couple more websites. Care Search is an Australian website run and supervised by Flinders University. Great information for carers, for professionals, on aspects of palliative care. And My Values is another Australian website about advanced care planning and comes out of Barwon Health in Geelong. And it was the Respecting Patient Choices program. So, to advanced care directives, I've got the South Australian version up there and the WA versions. An advanced care plan is really something that is your values, your wishes, your thoughts, and how you would like to be looked after. And that's the booklet and some of the headline topics of how you might go about it. I've just lifted that straight from advanced care planning. It's a discussion of what's important to you, and it does cross over into a healthcare directive a little bit. But talk to someone. Talk to your GP, gather your thoughts. Put them in writing and make them known. And then let others know. The Advanced Health Directive is more specific about what care, what treatments you would like or not like to have. And that could be an operation, that could be chemotherapy. For my motor neurone disease patients, I don't want to be kept alive artificially when my breathing is such that I need 24 hours of ventilation. Or I don't wish to have an artificial feeding tube inserted. And often they're things that I don't want, but I try to put in there, and you can see this in the South Australian version. These are things that are important to me. So this is the South Australian version, and it's a mixture of the two, the Advanced Care Plan and the Advanced Health Directive. So you can see here the substitute decision maker is the person that I give my authority to make decisions if I am unable to do so. And what's important to me? Well, my family, my friends, independence, having my dog is very important. You can read there, if I have a mental health episode, I would prefer to be given my usual treatment at home, not be put in care. I don't want my life prolonged if I can't communicate or recognise my family. And I want to be in a comfortable environment surrounded by my family and friends. And this is the bottom, I couldn't quite fill it in, but this is similar to the Advanced Healthcare Directive of refusals for or against having treatment. If I have a terminal illness, I do not want any life-sustaining treatment. Please keep me comfortable and pain-free. And at first glance, you look at that and you think, oh, actually, well, that makes sense. And it does when you appreciate that an advanced care directive only comes into play when you are unable to make your decisions known to me. And they're not perfect, because if you're very early on in a disease process but you have pneumonia, it might be worthwhile treating that pneumonia. But if you're unable to make decisions, if you're unable to communicate with me, that's when the Advanced Care Directive would come into play, and I could say, okay, she's written this, that she doesn't want to be kept alive artificially if she's in such a poor condition. So sometimes there's a bit grey, these advanced care directives. So how do we do it? Have a series of conversations. It's one little step at a time. By doing it, it may take the burden off the family. Share the plan around, talk to your GP, because they are vital people. Even though they are time poor and often rushed, they are really important people in your care. And really, it's the care decisions is a statement of values, wishes and preferences. And one of our nurses said, a patient in the hospice recently, a young woman said, I just want to be in a safe and a warm environment. And that's what the hospice often provides, is a safe and warm environment. So it really is what's important to you, trying to put you at the centre of the planning and the care. So living well is a daily choice, and we need to live well and do the right things, look after ourselves. Dying well does take planning. And by planning means we take some of the stress off family members. They don't have to guess what might have been important. I want to touch on caregivers. It is exhausting. It is relentless. It is just hard work. And often you're doing it alone, often you are sleep deprived, often you're trying to do it by yourself and work and clean the house and cook meals. And so sometimes as a friend, just having a meal delivered can be helpful. Sometimes just saying, I'll look after the kids, you have some downtime. Or as a friend, give me the shopping list, I'll go and do it for you. Or do you want me to sit with your husband while you go out and do the bills, get the shopping, have coffee? So caregivers, it is exhausting. And I think they do sleep with one eye shut, and I harp a lot on motor neurone disease because I run the clinic in South Australia. But when you think about a person who can't move, they can't roll over in bed. So to get comfortable, they have to fully wake up, and then they've got to wake their partner up so they can roll to get comfortable. So neither the patient or the partner are getting good quality sleep, and they may need to be rolled several times a night. So it is exhausting, and that's where specialist palliative care services and home services such as Silver Chain try to help to provide the care, to provide the support. We have a complementary care service at Repat for massage, relaxation. We've got an art therapist, so it's some downtime. But it's not perfect and it's not enough. And we can't provide 24-hour care because we're just not funded for it. But it is exhausting. We try to do our best. So did David Bowie. He died just over 12 months ago. But I do wonder, did he exemplify many of the things I've talked about, that he planned his death and his dying? That Black Star, which was the album he released a few days before he died, January last year, is the only album that did not have a picture of him on its cover. He was recording that whilst he was having chemotherapy for his cancer. And you can see in his heyday, up on the top left-hand side, he provided us with so much. His music was absolutely brilliant. And the bottom two pictures, the right-hand one was just a few months before his death, I believe, at the launch and the opening of Lazarus, which was the musical theatre production he put on. And then just briefly before he died, in a pretty sharp-looking suit. So he really did exemplify. He was living, he was preparing, he was planning. And in his death, the critics and the reviewers have looked at his lyrics. And the opening line to Lazarus is, "Look at me, I'm in heaven." It's quite a staggering opening line when you think about it. Did he think he was writing and singing to us from beyond the grave? And the last line in Lazarus is, "Look at me, I'm free." Just like the bluebird, I'm free. So do we interpret this just like we tried interpreting John Donne's sonnets, that he was writing that I will be free, that my dying will release me from this cancer? But I do believe he died at home, he died with peace, he died with his family around him. He prepared and he planned, and he did it pretty well by all accounts. And he did it very quietly, without any fanfare. The only people that knew he was unwell were the guys that he was recording Black Star with. So I do wonder, did he exemplify what I've talked about today with planning to make it easier? Thank you very much for your time.
Well, thank you very much, Peter. And the idea of being prepared, I hope, is something that you'll take away with you today. But we do have some time for questions. We'll be using the roving microphone. So if you have a question, can you please raise your hand, and the microphone will come to you. And then if you could then, for the recording, we will be able to hear your question as well. So can you just ensure that you're asking us a question and perhaps leave a lot of the statements out so we can get as many questions answered as possible. So are there any questions? Down the front here. Thank you, Hope.
Hello, and thank you very much. My name's Hope Alexandra, and I'm a health consumer advocate. And I think you just taken some of my thing, because I put in an abstract for the gerontology conference here in Perth, the conversation we need to have. So thank you. And what I want to tell people is that the virtualmedicalcentre.com asked me to do 3 videos on death and dying and how to make a good death, and a bit about palliative care. And they just asked me, because I'm on their editorial board, but I'm a non-medical person, but I've got a master's in public health. So if anyone wants to look it up, they can. And the other thing is from a doctor GP wrote in the Medical Observer, I look after people who are dying all the time. People go all funny in the head when relatives die. In my experience, it is rarely the person who is dying that feels distressed. It is the person watching them. And you said doctors don't have much time, but I have a wonderful GPs who said it takes the time it takes to help the patient. And in one instance, for me, it was 4 hours. So don't ever underestimate the power of our GPs and their consideration for patients. Thank you.
Yeah, I would agree with that. The GPs are, as I said, the vital linchpin. And I talk about GPs being the conductor of the orchestra, that as a specialist in palliative care or a specialist in respiratory medicine, that I come in and I do my solo, but the GP is the conductor of the orchestra, and we need to keep them in the loop. And the good GPs, the family GPs, do take time. The practices, the 24-hour chains that are set up with production-like medicine, take a ticket at the booth, I get distressed at. But what I find is that when patients really want to talk to their GP, they go back to the family GP, but when they want a quick script, they go to a 24-hour clinic. Mm-hmm.
Up in the corner there, thank you. About 4 rows down, lady in the red.
Thank you. Do you think people don't want to talk about it because they are afraid of the person who doesn't instigate the conversation? Are they afraid of causing the person with the illness distress or causing themselves distress?
It's probably a bit of both, isn't it? I think that the patient may not want to bring it up because they're trying to protect their family. The patient may not bring it up because they're trying to protect themselves. And equally, the partner may not want to bring it up. And particularly sometimes in different cultures, you have to be very sensitive to how it's brought up. And with our Indigenous Australians, it's actually not the patient, but it's the family that makes decisions. So trying to work out who the spokesperson is and who to talk to is important. So I think it probably is both ways. Do I bring it up? Should she bring it up? And people worry about it being self-fulfilling, that if I talk about it, it's real and it'll happen. So it's probably both ways, I think.
Do you think it's worth giving it a push, or it's not anybody else's place?
I do give it a bit of a push. If I'm talking about, say, to one of my patients, I may use words. I try to avoid euphemisms, but I tell stories a lot. And I say, I'm really worried that you're getting worse, or it worries me because of. And sometimes I even said, is this getting so tough that if you didn't wake up tomorrow, would that be a blessing? As a way of opening up that conversation. Often they'll say yes. And then you can explore that. Sometimes you do have to give it a little bit of a push, but that's where I fear for our junior staff when they're given this piece of paper, the 7 steps, and you've got to have this do not resuscitate in order written in. It's just so artificial, and it's not fair on junior staff because it's a series of conversations. As a palliative care physician, sometimes I'm asked to do consults, and they say, oh, you've got to get the do not resuscitate order. And that's where they see my role. And it's much more than that. It's actually sitting down and saying what's important to this person. So I do give it a little bit of a push, but it is hopefully a gentle push and a sensitive push with subtleties, I hope. I'm sure I don't get it right all the time.
Just a second.
Thank you. I'm just wondering about the Advanced Health Directive and who needs or gets that form, and if it's the same for every state.
It's not. We all have different forms in different states, but it's under various state legislative processes. So WA's got a different book that looks different to SA. But they would cross boundaries if you moved. If you were in South Australia and you were travelling and you needed to enforce your Advanced Health Directive because you were in WA, it would still be binding. Who needs one? You could say, well, we all need one because I could come off my bike this weekend and have a severe brain injury. I actually haven't got one in place. I have to tell you. My family knows, my friends knows. The intensive care doctors have actually said they'd be lining up for my organs because they're pretty healthy. But so we all should have an Advanced Health Care Directive if we are unable to make those decisions. But I think it becomes imperative of us, not when you're just diagnosed with a cancer, but before it becomes progressive. And I think about my sister-in-law, Margie, who died 10 years ago in the States, and she had a glioblastoma. Now, when she was on the steroids for her radiotherapy and her treatment, she was quite manic, and she got a will done, she got the finances done, but she didn't want to talk about dying. And unfortunately, as part of that illness, she lost the ability to speak. And then she lost the ability to understand speech as well. And so whilst she lived in America for 20-odd years, she'd always said to Meredy, my wife, I wish I could have come back to Australia. I love the Southern Cross. I love the Southern Stars. But she never got back to Australia. And when I was running around Kings Park this morning, because Margie played in the World Champs there on the tennis, she was, a world legend in tennis. But she never talked about coming back to Australia to her husband, who was a staunch Catholic, Italian Catholic. And when she died, Russ wanted to have her buried. But we knew she wanted to be cremated and her ashes brought back to Australia. And if she'd put an advanced care plan / health directive in place, that would have helped. And we also had the difficulty because Russ was struggling with his staunch Catholic beliefs that she has to be buried, she can't be cremated. So we all should put one in place, but particularly when you have an illness such as a cancer or a progressive illness which, like emphysema or motor neurone disease, particularly one when you're going to lose the ability to speak, it should be in place. And they're all similar forms, and I guess it doesn't have to be on form, but it's got to be written somewhere. And the WA one needs to be witnessed by two people. One can be any person, and then the other is a member of a huge variety of professions, be it a public servant, the post office manager, doctors, lawyers. When I looked at the list, it's interesting, social workers aren't on the list, and occupational therapists weren't on the list, but any health professional. And those are easily available online.
Okay, well, thank you. I think we've come to the end of our time. Thank you so much, Peter. And can I just say that all the resources and some of the forms, etc., that we've been talking about today, we'll make sure are linked through the Cancer Council website and the Cancer Council update series. We seem to say Cancer Council an awful lot, don't we? But it'll be there for you. So we'll ensure in the next week those links are all there so that you can access them. Can I just remind you that don't forget to do your evaluation forms and place them in the box on the way out. And if you want to find out any more about education lectures and these events, do go to our website, as I've said, and that reminding you that if perhaps you have somebody that you wanted that couldn't be here today to be able to see it, that the presentation and the link to the audio will be available on our Cancer Council website as well. I wonder if you'd just take the time one more time to thank Peter for us, and thank you for attending. Thank you.